Welcome to the Human Health Campus Basic Nuclear Medicine webinar series. This webinar is entitled Introduction to Inflammation and Infection Imaging and is presented by Dr. Riddhika M. Chakravartty from the FEBNM on behalf of EANM Inflammation and Infection Committee. I am pleased to present this seminar to you on behalf of the Nuclear Medicine and Diagnostic Imaging section of the International Atomic Energy Agency in collaboration with the European Association of Nuclear Medicine.
I'd like to go through this presentation looking at the pathophysiology of inflammation and infection. We'll also look at the nuclear medicine imaging of this modality, including the radiopharmaceuticals used and specific clinical conditions where the radiopharmaceuticals can be applied. This is an introductory overview to infection and inflammation imaging. Today's learning objectives include learning about the pathophysiology of the inflammatory process, understanding the difference between inflammation and infection, understanding the targets for radiopharmaceuticals that help image the inflammatory process, and based on all these concepts, understand the strategies behind infection and inflammation imaging. Inflammation and infection. Are both of these synonymous? Well, the Steedman's dictionary gives two different definitions. Inflammation is the localized protective response of the body to irritation, injury, or an infection. On the other hand, infection is the invasion and multiplication of pathogenic microorganisms within a body. This may result in an inflammatory response. Inflammation has several clinical features by which the doctor in the clinic picks up the presence of inflammation. These were described almost 2000 years ago by Celsius, and the first four pillars or clinical features of inflammation are heat or calor, redness or rubor, swelling or edema, pain or dolor. A fifth pillar was added by Virchow, which was loss of function. Inflammation, as we mentioned earlier, is the defensive host response to a variety of foreign bodies as well as necrotic tissue and toxins. The main components of inflammation include a vascular response where blood vessels dilate and have gaps in their endothelial lining, and this is followed by a cellular response where the white blood cells within the body mount an inflammatory response to contain the invading foreign body. Both of these are activated by mediators in the plasma proteins and from various inflammatory cells, often known by the name cytokines. The inflammatory response has various steps, and these can be remembered as the 5 R's. These are recognition of the injurious agent, be it a pathogen or an autoimmune antibody. This is followed by recruitment of leukocytes to the area of infection or inflammation. This is followed by removal of the injurious agent. It's then followed by control of the response. And finally, there is resolution either by repair or fibrosis. This diagram looks at the various mediators and cells involved in the inflammatory process. These include the polymorphonucleosides, seen in acute responses, while the lymphocytes and the monocytes are mediators of the chronic inflammatory process. Mediators or activators for the inflammatory process include nitric oxide, cytokines, and other complement mechanisms. Vascular permeability is an important part of the inflammatory process, and this is usually maintained by a balance in the hydrostatic and the colloid osmotic pressure. However, in inflammation, under the influence of the acute phase reactants and cytokines, gaps appear in the endothelial lining which allow the cells to migrate through this thin vessel wall into the areas of inflammation. This is very well studied in nuclear medicine because it is the vascular permeability which allows the radiolabeled cells to migrate to the areas of inflammation and hence allow them to be imaged. Leukocyte recruitment is another important part of the inflammatory process. Leukocytes, once activated by a stimulus, roll towards the vessel wall and then adhere to it. Once they've adhered to the wall, they can then slip out through the margins and the gaps in the endothelial lining we saw earlier and then migrate towards a chemotactic stimulus in the tissue provided by the cytokines. The acute inflammatory process has various endings. The usual case scenario would be a single event of an injurious agent, and this, in the best case scenario, leads to resolution where after the process the tissue is returned to its original state and function. However, this is not the only scenario. Should there be a superimposition of an infectious agent over the inflammatory process, there could be formation of an abscess. Acute inflammation also resolves by scarring in the surrounding tissue. This may lead to a loss of function through fibrosis. Finally, the injurious agent may present not once but many times, leading to a chronic inflammatory process, and this process is often resolved by scarring and loss of function. Hence, we see that though inflammation is a protective response, the response and resolution of inflammation is not always a positive one, as there can be a loss of function in the tissue involved. I'd like to demonstrate the difference between acute and chronic inflammatory processes. The acute process is granulocyte or neutrophil mediated, while the chronic process relies more on the mononuclear cells such as the monocytes and the lymphocytes. Other factors which differentiate acute from chronic inflammation are the onset of this process. It's usually very fast in an acute case, while chronic inflammations are insidious. Cell injury and tissue fibrosis are usually self-limiting and mild in acute, while chronic inflammation is characterized by slow and severe progressive fibrosis. Clinical signs, like the clinical pillars we saw earlier, are more prominent in acute inflammation, while chronic inflammation may have more subtle clinical features. We now move on to infection. Infectious diseases form an entire subspecialty by themselves because they contain such a large variety of infectious agents. These range from prions, which are tiny at less than 10 nanometers, to helminths, which can range up to 10 meters. A majority of infectious agents that we routinely encounter are bacteria, viruses, and fungi. And in developing countries, this forms a massive burden of disease. In more developed countries, infectious diseases are common among the elderly, patients with retroviral diseases, and on patients receiving immunosuppressive drugs for autoimmune conditions or for cancer. As we mentioned before, infective agents elicit an inflammatory response, and the body responds to infection in various ways. This could be suppurative, where there is acute tissue damage, increased vascular permeability, and leukocyte infiltration. This is most commonly seen in pyogenic bacteria, and this often results in a liquefactive necrosis of the tissue known as a pus pool or an abscess. More chronic inflammatory processes are also possible with bacteria, such as the tuberculosis bacteria, which elicits a granulomatous response. Viruses can produce a cytopathic or cytoproliferative response, and this results in a sparse cell-induced inflammatory response with mainly cytokines resulting in cell necrosis or cell proliferation. Certain bacteria, such as the Clostridium perfringens bacteria, secrete powerful toxins, and this can result in rapid and severe necrosis. Tissue damage is a prominent feature in the necrosis process. Finally, there is chronic inflammation or scarring, which then can resolve either with complete healing or extensive scarring and loss of function. A word about biofilms. Biofilms are an interesting concept. They are a collection of bacteria that reside over a solid and liquid interface. One can think of them as a bacterial collection over the surface of a boulder in a stream. Medically, biofilms have become more and more important because of the various devices and catheters that we use in routine clinical work for medical treatment. Bacteria can reside on these surfaces, forming a biofilm, and unfortunately, a lot of these are now the cause of hospital-acquired infections. The problem with biofilms is that the bacteria within them show an upregulation of genes, particularly those which cause antibiotic resistance. So, in fact, a lot of infections caused by biofilm organisms are likely to be multi-drug resistant. So, why do we image infections? Well, we could confirm that there is a presence of an infectious agent, and we can also localize the source. We also study the extent of the reaction in order to minimize complications from its spread. We can then plan treatment and intervention, including targeted biopsies. And finally, following antibiotic response, we can assess response to treatment. These are some routine radiological modalities showing infection and inflammation. The chest X-ray here shows increased consolidation in the left lung, possibly due to an infection, while the CT scan here shows increased vascular stranding around an inflamed appendix, a sign of appendicitis. Neck nodes are often studied by ultrasound, and it is the increase in the size of the node with the loss of the fatty hilum which suggests that this could be an infectious or an inflammatory process. Finally, the MR shows a change in signal intensity in the calcaneum, suggesting that there could be an osteomyelitis reaction. However, radiology is poor at differentiating infection and inflammation. A sterile infection rarely needs treatment, while an infection requires antibiotic coverage. Nuclear medicine imaging, particularly using various specific tracers, is particularly good at differentiating an infection from inflammation. In this example, the altered signal intensity following a month of antibiotic treatment on an MR did not definitely resolve an inflammatory process from the presence of residual infection. However, this technetium labeled infect on agent imaging shows focal uptake in that area to conclusively prove that infection was present and that antibiotic treatment needed to be continued. We have a large armamentarium of pharmaceuticals for infection and inflammation imaging. They fall under various categories: antibiotics, antifungal agents, antimicrobial peptides, and even vitamins. However, more commonly used are agents which image the inflammatory process itself. We will look at some of the more commonly and routinely used radiopharmaceuticals. These include gallium citrate, labeled white blood cells, labeled monoclonal antibodies, and finally fluorodeoxyglucose. This is an interesting case to start with. This was a 44-year-old man on retroviral medication with breathing difficulty. His X-ray did not show any features of consolidation, but his oxygen saturation remained persistently low. He underwent a gallium citrate scan and findings. This image is actually a picture of the normal distribution of gallium citrate, showing its concentration in the liver, the gut, and the reticuloendothelial system. In contrast, if we were to see increased uptake in the lungs, as we do see in the case on the right-hand side, this would suggest the presence of pneumocystis carinii infection, an infection very commonly seen in patients on retroviral medication. Gallium citrate is a ferrous or an iron analog which is carried on the transport proteins transferrin and lactoferrin. These interestingly act as acute phase proteins or inflammatory mediators and hence do develop in areas where there is acute inflammation. The iron or the gallium bound to these proteins is hence carried to the areas which can then be imaged. An alternate theory is that some bacteria have receptors for transferrin and lactoferrin, and hence also carry gallium citrate to these areas where they cause infection. Gallium citrate has long been the warhorse of infection imaging, and its primary advantage is that it does not need cell labeling. This is extremely useful if the patient is neutropenic or if the infection does not localize labeled leukocytes such as pneumocystis carinii on the previous slide. It is also useful if blood is contaminated with hepatitis or HIV viruses, making it a safer option for staff. To ensure we get the best results from our gallium citrate imaging, we do need to ensure that the patient is not on iron chelators. We also need to consider stoppage of antibiotics, as antibiotics can dampen the inflammatory response. Some centers advocate bowel preparation with laxatives to reduce the bowel uptake and excretion of gallium citrate. However, there isn't any convincing evidence that this is actually useful. If gallium is being used to diagnose sarcoid infections, it is better to avoid high-dose steroids in these patients, particularly for more than a week. We now move on to labeled white blood cell imaging. And this has been long the gold standard for bone and soft tissue infections because of the high diagnostic accuracies reported in literature. White blood cells have often been labeled a laborious process because this requires meticulous attention to detail as well as sterile conditions, often requiring class A sterile conditions. And of course, different countries have different local regulations governing the labeling of white blood cells. White blood cells can be labeled either in vitro, outside the body, which is more commonly done, as well as in vivo, which is within the body. In vitro, radiolabels commonly used are indium oxide and technetium labeled HMPO, while the PET labels of FDG and copper are now being considered. So the question often asked is which radiolabel for a white blood cell? Well, this depends a lot on the clinical condition that needs to be imaged. Indium oxide has a longer physiological and biological half-life, being an ideal agent to image a chronic inflammatory process. Technetium labeled HMPO, on the other hand, has a half-life of 6 hours and hence is better for imaging, which would require the ideal attributes of technetium for a gamma camera. Hence, SPECT-CT is often performed with HMPO imaging. Delayed imaging is possible up to 24 hours with HMPO, and in fact, this is something that should be more routinely performed rather than completing imaging at 4 hours. The EANM Infection and Information Committee is very proud of its guidelines on WBC labeling. There are two of these for labeling leukocytes with indium oxide and that for labeling leukocytes with technetium HMPO. And both these guidelines are freely available on the EANM guideline webpage. These guidelines form a comprehensive overview of WBC labeling and provide a meticulous checklist, very useful if you are planning a standardized operating procedure for your department. To get the best out of a WBC cell scan, it is essential to have a detailed clinical history, particularly an antibiotic history. It is worth liaising with the treating physician to consider stopping antibiotics for at least 3 days, ideally 7 days, as antibiotics do dampen the inflammatory response and reduce the sensitivity of the scan. Good intravenous access is crucial as there needs to be a sufficient number of white blood cells collected to ensure labeling efficiency and adequate targeting. This graph appears very busy, but I'd like you to concentrate on certain lines. The black line shows lung uptake, which we can see during the first phase of imaging of WBCs early on in the first hour is at its peak and then falls to a trough. This is known as margination of white blood cells and is an important visual quality control of the labeling process. I'd next like you to focus your attention to the green lines. These are the lines representing accumulation of WBCs at sites of infection and inflammation. As you can see, all of these lines show an increasing trend. They all rise from very little accumulation early on to larger phases of accumulation, peaking perhaps at 24 hours. Differentiation between an acute, subacute, and chronic infection is rarely possible on WBC scans. However, it is noted that chronic inflammations show the least temporal variation as compared to an acute inflammatory process. So to confirm that one actually is looking at an infection by increase in WBC accumulation, we look for an increase in the concentration or the activity over time. This scan shows increasing activity in the right hip joint with almost no activity at 1 hour, a minimal amount of accumulation at 4 hours, but a definitive area of increased uptake at 20 hours. Another criteria is also an extent in the increase of uptake, which is clearly seen between the 4 and the 20-hour imaging, with a far larger area of uptake on the 20-hour imaging over time. An interesting case. This is a 52-year-old lady with fever of unknown origin with multiple daily spikes and no response to first-line antibiotics. She underwent an indium-labeled white blood cell scan to look for the source of the infection. Unfortunately, this white blood scan did not reveal a source of infection. In fact, the only area of increased uptake was within the spleen, which is a physiological site for WBC accumulation for destruction, often seen during an inflammatory process. WBC imaging is often followed by bone marrow imaging because WBCs accumulate not only in areas of infection and inflammation, but also in areas of regenerating bone marrow. It is important to look for concordance or discordance between the labeled white cell images and the nanocolloid images, which show the accumulation within the bone marrow. A concordance between imaging, both on the WBCs and the nanocolloid imaging, suggests that infection is not present, while a negative accumulation on the nanocolloid with a positive uptake on our labeled cells is more definitively positive of an infection. We now move on to another concept in radiopharmaceuticals for infection imaging. When one cannot label the WBCs themselves, we can then target the WBCs through antibodies to them, often mouse-related antibodies to human white blood cell are used, and these can vary from the complete antibody in its Y tuning fork shaped structure to FAB fragments, which are the prongs of the tuning fork broken down by Papin to, and then labeled to either technetium or indium. To prepare the patient for monoclonal antibody scanning, it is essential again to stop any antibiotics at least for 3 days, optimally for 7 days. Some countries have a legal requirement to perform a blood test to show negative human anti-mouse antibodies or HAMA antibodies before monoclonal antibodies can be injected to a patient. This is a legal requirement because of the immune response that can be mounted by these HAMA antibodies, which can often even lead to disastrous consequences. So technetium-labeled antigranulocyte monoclonal antibodies are generally licensed for osteomyelitis infection. However, they can be used in almost any situations where labeled white cells could be used. However, they have been seen to be not optimal for inflammatory bowel disease due to a cross-reactivity with the carcinogenic embryonic antigen, in vertebral osteomyelitis in the spine, and also in neutropenic patients where there are less white blood cells to elicit a response to the monoclonal antibodies. Two types are available. Both of these are labeled with technetium-99. The first of these is technetium-labeled basilosumab or Sintimon. This is a whole mouse antibody directed against the CD66 glycoprotein on the WBC. It's primarily been used in bone and joint infections and shows a rapid uptake in acute infection, particularly on delayed images. Being an entire antibody, there is a theoretical risk of HAMA reactions. The second variety is the technetium-labeled solisumab or the Leucoscan. This is the FAB fragment of the mouse antibody targeted to NCA 90 glycoprotein, and then being a FAB fragment does not contain a real risk of HAMA. Hence, it can be used more than once without the risk of eliciting more and more HAMA responses. Solisumab has a high background activity, and one does see uptake in the bloodstream, in the urinary tract, and in the gut. Hence, it is licensed mainly for use in peripheral infections, either in the limbs, in the bones, or the joints in the periphery. The technetium label does mean that SPECT-CT can be applied, and this may be of help in a clinical scenario. We now move on to fluorodeoxyglucose, or the holy grail of PET imaging. FDG uptake is primarily used for cancer imaging, but it was often seen that there was uptake in non-cancerous cells, particularly those involved in an inflammatory or an infectious reaction. This is because the inflammatory cells express high levels of the glucose transporter, particularly the GLUT1 and the GLUT3 variety, and this allows the cell to actively take up FDG and trap it within the cells. The radiolabel fluorine 18 then allows PET imaging to be placed, and then the areas of infection and inflammation can be further imaged and studied on PET. This interesting slide from the Annals of Anatomy shows the staining of GLUT1 and GLUT3 using antibody staining, and this area of increased brown uptake in inflammatory tissue proves that there are GLUT1 and GLUT3 overexpression in inflammatory cells. Our committee participated with the SNMMI to produce a joint guideline for the FDG use in infection and inflammation. This again can be found easily on the EANM guideline webpage. Patient preparation for FDG PET scans is essential in terms of a detailed clinical history. Antibiotic history is needed, but stoppage of antibiotics is not essential. Fasting is required for 4 to 6 hours, as in a standard FDG PET scan for oncology. This is to allow FDG to leach into the inflammatory cells. In inflammatory conditions, strict blood glucose level is not mandatory. However, for the ease of the interpreting physician, blood glucose levels less than 200 milligrams per deciliter provide better quality imaging. For patients undergoing FDG PET scans for sarcoidosis, particularly cardiac sarcoidosis imaging, a detailed protocol exists with prolonged fasting and dietary modifications to allow for this particular condition to be imaged effectively. This is an FDG PET scan of a 67-year-old gentleman with fever of unknown origin. He had a low-grade pyrexia, spiking mainly in the evenings, but no localizing symptoms. The FDG PET scan should increase uptake within the T12 vertebral body. And it is interesting to note that the uptake is best visualized on an attenuated corrected image as compared to the non-attenuated images where the uptake may be masked due to central attenuation. The CT image, and particularly the fused PET CT image, help to localize the uptake precisely to the vertebral body, where the presence of cement suggests that this is an inflammatory response to the cement present from an earlier bone surgery. Have a look at these two images and see if you can name the radiopharmaceuticals involved. The upper images show an FDG PET scan, and this shows both uptake in inflammatory areas such as that around a prosthetic knee joint, as well as various areas of inflammation by arthritis. The lower images refer to FDG labeled white blood cells, and this is a newer tracer being used to look at acute infections, particularly harnessing the power of PET to predict areas of very subtle infection. As you can see, The WBCs here are localized in a particular area in the right ankle, and this is a soft tissue infection which can then be drained. So if we go through what we've learned today, inflammation is the body's protective response against harmful stimuli. It can be acute or chronic. While most inflammatory processes aim to resolve the tissue to its original state of functionality, some inflammatory processes can actually cause considerable harm. This can be due to fibrosis, which leads to a loss of function. Infection is the invasion of the body by pathological microorganisms and the reaction that the host tissue presents to these organisms as well as the toxins that they produce. Infection is almost always accompanied by an inflammatory response. However, inflammation is not always the consequence of an infection. Inflammation can be caused by an autoimmune response or even the presence of a foreign body or an injury. Nuclear medicine aims to differentiate sterile inflammation from septic infection. Sterile inflammation rarely requires antibiotic treatment, which is the mainstay of treatment for septic infection. A number of radiopharmaceuticals can be used to image infections. These use various agents, some of which being antibiotics, vitamins, and more commonly white blood cells and other mediators of the inflammatory pathway. Gallium citrate is the old warhorse of nuclear medicine infection imaging. It is a non-specific tracer. Radio-labeled white blood cells and antigranulocyte monoclonal antibodies are non-specific inflammation and infection agents, but using standardized protocols of acquisition and interpretation, often in conjunction with bone marrow imaging, one can differentiate infection from sterile inflammation with a high diagnostic accuracy. EANM guidelines exist for labeling white blood cells, and we would urge you to refer to these. FDG is another non-specific radiopharmaceutical and is commonly used in various inflammatory conditions, commonly in large vessel vasculitis and sarcoidosis, but it also seems to have found a role in infectious endocarditis, cardiac implant device infection, as well as in spondylodiscitis.